Welcome to the second session of the Physics SIG Symposium. Thanks to the chairs. I just want to quickly make an announcement, and that is that we're going to have a physics social event, the Happy Physics Hour, probably more than an hour with any luck, Sunday evening from about 5:30, and it's going to be in the Munich Brew House, which is, if you just go out of the main doors of the conference centre towards the river and turn left, it's about 50 metres away. Okay, so it's very easy to find. So bring yourselves, bring your friends, bring your physics groupies, and so it's happy hour, $5 pints of German beer and $1 wings and $5 wines and those sorts of things, so that we can get a bit happy. And we don't have to talk about physics, but I think that's probably unavoidable given that we're physicists. Yeah. All right, thanks, chairs.
Thank you very much. I'll just go through a couple of the housekeeping points. So to try and make sure the session runs to time, just for the speakers, just try and keep to the 15 minutes in total. And if you're getting close, we'll give you a warning about 1 minute to go. Just for everyone else, can you please make sure your mobile phones are turned off? Told to remind you there's an app you can download to get all the information as well. And I think that's about it. Keep refreshing the app to make sure it's up to date. I think that's the end of the announcements.
Yeah, we do have questions afterwards, so there's a mic set up. So if you do have any questions and we have time, we'll basically ask you to go to there and give an announcement. So we'll start with the first speaker. So the first speaker is Ms. Raman Hidrayati, and she'll be talking about reproducibility of radiation dose to kidneys for multiple lutetium dotatate treatment. Thank you.
Good afternoon, ladies and gentlemen. Thank you for moderator. I would like to start with my talk about reproducibility of radiation dose to kidneys for multiple treatment cycle. This article actually is a result of my scientific visit to Royal North Shore Hospital in 2017. So this work has been done with from several institutions, from Austin Health, from Royal North Shore Hospital, of course, and University of Sydney. Let me start with the outline. And what is the aim for our works? It's like the first one. We want to compare the estimated radiation dose to kidney to each cycle, and to test whether full imaging over multiple days for the initial cycle can be used to estimate kidney dose for subsequent cycles. Besides this aim, actually my visit was to learn about radiation dosimetry and nuclear medicine therapy, because in Indonesia we haven't done any radiation dosimetry in any nuclear medicine department. So I'm the researcher who started this radiation dosimetry for nuclear medicine therapy, and I would like to learn from Royal North Shore Hospital. That was the aim my visit. Okay, talk about neuroendocrine tumor. We know that neuroendocrine tumor is neoplasm originating from endocrine cell that secrete biogenic amines and polypeptide hormones. This tumor has dispersed endocrine cells in the respiratory and gastrointestinal tracts, and it has various clinical behaviors, harmonically active of endocrinology non-functioning. We found that the number of incidents of neuroendocrine tumor has been increased worldwide. We know some data from US and Canada. Also in Australia, it has been increased about 1.7 in 1980 to 1989, become 3.3 in 2000 to 2006. So this data come from US, that they have show how much the incidence of NET has been increased starting from 1973 to 2012. If we can see that from 1985 become to 2012 is like about 400 or 5 times multiples. So for treating the NET, most of radionuclide therapy using the this kind of radionuclide therapy, which using peptide receptor, and this peptide receptor radionuclide therapy is use radiolabeled peptides as biological targeting agent. So there are some radiopharmaceutical that has been used, such as indium 111, yttrium-90, 177, lutetium 67, cuprum, and scandium 47, and from that all available radiopharmaceutical, lutetium 177 is the most widely used radioisotope for use in vivo procedures and targeted radionuclide therapy. Also, there is a journal article show how the progression of survival of 177 lutetium is good. I can show, there is a table to show that. And lutetium 177 dutatate has been acknowledged as potential radionuclide for therapeutic procedure during past decade. It also has a lower delta particle energy and shorter range, and may be more effective in treating small lesion. So most PRRT using around 150 until 200 millicurie, about 5.55 and 7.4 gigabyte of 177 lutetium dutatate. This is that I show you that progression-free survival for dutatate. It's good among of another radioisotope, so it's come from Quickboom article. And we consider that kidneys is the critical organs in PRRT. So for limiting dose, most of journal article refer to, actually it's referred to external beam radiation, but that we found that most of PRRT set 23 gray as the dose limit. At the moment, we found that 17 patients with 3 cycle and about 9 patients and 8 patients with 4 cycle treated with lutate for metastatic NETs. And we scan for the patient for 3 time points, 4, 24, and 69 and 120 after the administration. The volume of interest has been defined using a CT scan, co-registered with SPECT image, and repeated over all time. After that, we calculate the organ dosimetry using all-in-die XM version 1 to develop the kidney dose. So the result is we found that the mean amount of lutate administered was 7.76 plus minus 0.36 gigabyte, and the average kidney dose was 0.23 gray per gigabyte. Another one is we found that there is a good reproducibility, typically mean less than 20% variation within all individual across all cycles within one course of treatment up to 4 cycles. So for the conclusion, we found that the error introduced by assuming that dosimetry estimate per unit gigabyte administered from the initial cycle can be used for subsequent cycles within a course are unlikely to contribute significantly to the overall estimate of radiation burden and are likely to be safe. There is acknowledgement. The first acknowledgement I would like to thank to the Ministry of Research and Technology and Higher Education Indonesia that give me the travel award for visiting Royal North Shore Hospital in November 2017, and also to the head of department and the staff of Nuclear Medicine Department, Royal North Shore Hospital. Thank you.
Okay, we have time for questions. Is there any questions?
Yes.
Can
Do you
I
want to
just ask your method for the dosimetry? Was that planar scans or were you doing it with spec scans?
We doing it with SPEC CT.
Oh, thanks.
Yes.
Yes.
You're probably aware that Olinda is explicitly not intended for individual dosimetry.
Yes.
Did you make any alterations to the dose factors associated with kidney doses on the basis of individual kidney mass or position or shape?
I'm not sure about it because at the moment this is like a work together within like 4 people, like, and I'm doing the last part of the using the Olinda, but at the moment Prof. Del Bailey and Katie Wilson also use the Olinda for the kidney dose, even this for the personal kidney dose. Is that what you mean? The dose factor. So we the dose factor. We only use the dose factor from Olinda, not from yes, yes. Sorry.
Any other questions? I have a quick question. So, how was the implementation in Indonesia with this process?
That's a very good question, because this year we got like II project, like coordinated research project in dosimetry. So after I implement the situation, actually it's not my first time visit to Royal North Shore. I was visiting there in 2013, but at the moment they haven't done the dosimetry for radionuclide therapy yet. But I'm still like have communication with Prof. Del Bailey. So I learned much from him, and he also visit us into Indonesia many times for Nuclear Medicine Society seminar. And yeah, last year I got the contract from IAEA research project about dosimetry and molecular radionuclide therapy.
So, will you implement this in Indonesia?
Yes, we working on it.
Great. Yes.
Quick question.
Yes.
Is it predictive dosimetry you did pre-therapy or you did the post-therapy dosimetry?
This work or my project?
Your project or your work?
In my project, we only did at the moment we only did the pre-therapy dosimetry, but this project is it's post-therapy, because they didn't I didn't calculate for the pre-therapy.
Why I'm asking if there is any difference between predictive or pre-therapy or post-therapy? Is there any difference, or the numbers are matching?
Pardon?
Because when you give millicurie versus
No.
200 millicurie, there will be a lot of statistical issues and time loss and so many other issues will come up. So that's why I'm asking.
For the post-therapy?
So the pre to the post. Is that what you're asking?
I am asking, she told she has done predictive, means pre-therapy.
Yeah, pre-therapy. Yeah.
And then she did post-therapy. Is there match or there is difference?
No, it's different. This work is about
Post.
my work. We haven't yet to do, because we just
Have you done pre-therapy, post-therapy? Check the.
yeah, we have pre-therapy, but we haven't done the post-therapy yet.
Any more questions? Okay, I think we'll move on to the next speaker. Thank you. Okay, next is Dr. Arjun Somasodram, discussing low-dose MAG3 renogram in adult and pediatric patients. And how low can we go?
All right, good afternoon, everyone. Thanks for having me here. So my name's Arj. I'm a radiology registrar at the Gold Coast University Hospital in Queensland in Australia. So the quest for ever decreasing radiation doses in imaging continues to drive a lot of research in our field, and my presentation today is based specifically on that same effort. Specifically, what we wanted to look at is relating to our departmental use of the MAG3 renogram in clinical practice and whether we can maintain a satisfactory diagnostic result with this test while lowering radiation exposure. So MAG3 renogram is a commonly performed nuclear medicine study that visually and functionally evaluates both renal blood supply and glomerular filtration. So in clinical practice, we commonly use it looking at renal function in patients with or without obstruction, and specifically we can use it to look at split kidney dose, or comparing the right and the left kidneys. So how it works, first we inject a small amount of radiotracer into the patient, which in this case we used technetium 99M MAG3. There's a number of other radiopharmaceuticals you can use, but for this study we specifically were using MAG3. Specifically with that MAG3. So we put in the injection, then we take multiple images of the patient, which has an appearance like we're seeing there. Basically it shows the kidneys, ureter and bladder outlined by the radiotracer excretion. Based on both the visual appearance as well as the quantitative data from the study, we can compare asymmetrical and overall renal function. The renogram imparts an ionizing dose onto the patient due to the use of the radiotracer. There's a recent publication by ARPANSA, which is the Australian Radiation Protection and Nuclear Safety Agency. So they published some guidelines, which are the national diagnostic reference levels in Australia, for common imaging studies and what their expected doses should be. And that sort of raised a bit of awareness about the ongoing requirement for dose optimization with our imaging. By limiting the dose of the radiotracer that you use, then the amount of radiation can be lowered, but this often comes at the trade-off of a lower quality study. It's a balance that you have to keep in mind, because if you tilt it too far and reduce your dose too much, then your study becomes non-diagnostic, it's a waste of time, it wastes effort, and ultimately it means that you need to give more radiation dose if the study needs to be repeated. So our facility's renogram activity dose as our standard is about 200 megabecquerel, which is lower than the national recommended level. The diagnostic reference level is 305 and the median is 270. But there are plenty of studies outside of Australia which show that you can get to even lower doses and still maintain sort of clinical usefulness. Ultimately, our aim is to determine how far we can reduce the dose for MAG3 renograms in our institution while maintaining diagnostic imaging quality in both adult and paediatric cohorts. The protocols and the equipment used at Gold Coast would differ significantly from what's used in these other studies internationally, and so this project was more developed as a way for us to evaluate and optimize our own local protocols, specifically based on our equipment. So we got ethics approval from the appropriate Gold Coast Health Ethics Committees. We selected 15 clinical renogram studies performed between April and July of 2017. And this range of patients covered a range of body sizes, as well as a mix of adult and paediatric. So we had 9 adults and 6 kids in the sample. Adult administered activity was 200 megabecquerel, and paediatric activity was linearly scaled by weight with reference to a 70 kilogram adult. And we made sure that with the paediatric doses that the minimum activity we'd give is 20 megabecquerel. And sort of these values that we used are pretty much in standard with what we do as routine practice. We then performed Poisson's resampling on these renograms to simulate 3 further studies, each with a reduced, simulated reduced dose of 75%, 50% and 25%. So in total, we now had 4 renograms per patient at 100, 75, 50, 25% activity. So a total of 60 studies to analyse. For the quantitative analysis, the percentage of differential kidney function was calculated, and a one-way ANOVA test for repeated measurements was used to assess the significance of any difference between each activity group. The qualitative analysis was a bit more involved. We had 3 independent observers. That was a dual-trained radiologist nuclear medicine physician, one nuclear medicine trainee, and a radiology registrar that had done a nuclear medicine rotation. And so each of them reviewed all 60 studies independently. The studies were all randomised as per patient and the administered dose, and then each observer categorised each study according to their diagnostic quality as either suboptimal, satisfactory, or excellent. All of those results were collated and aggregated, and then segregated according to patient and the dose that, the study quality. Of the 3 observer interpretations, we used the median score as our reference data point for the data. We also retrieved the most recent creatinine markers prior to the renogram for each patient, so we could use that as a sort of surrogate marker for their sort of serum renal function. A Kruskal-Wallis test for independent variables was performed to assess the significance of maximum kidney counts for each image quality score, and we did a chi-squared test for association to assess the significance and distribution of image quality score between the different activity groups. So results are, in the quantitative analysis, we determined that differential function is not compromised by reducing activity by up to 75%, and the satisfactory and excellent scores together remained unchanged. It's important to note that despite this being promising, you still have to visually interpret the images, both for diagnosis and for reported confidence in the data that we get back. So the Kruskal-Wallis test looked at the impact of counts per second in each study, and as you can see on this graph, it clearly shows that the number of counts was really the main key to maintaining a diagnostic quality study, whether in adults or in pediatrics, and this was a pretty significant result, and the p-value was 0.0001. The highest maximum kidney counts were all excellent, as you can see by the dark blue bar over there. And that's excellent quality as in what was determined by the observers scoring the image quality, while the most count poor images are all of suboptimal quality. And you can see here how the counts correlate exactly with what the image assessment was determined to be for each person. So over the 60 studies, we had 15 overall classified as suboptimal, 27 were satisfactory, and 18 as excellent. So as you can see from the graph, the 3 suboptimal cases at normal activity was the same, still 3 cases at 75%, increased to 4, and then 5 at 50 and 25% respectively. For reducing the dose between 100 to 25%, the number of excellent scores had decreased slightly from 6 to 2, while the satisfactory scores increased from 6 to 8. So despite the realization in the previous graph that image quality is so heavily reliant on the number of counts, we found that the administered activity didn't really correlate strongly with image quality, as you can see here. Suboptimal image quality isn't restricted to the reduced activity groups, and it was more other factors that seemed to have more of an impact, such as renal function, this initial dose we gave, particularly in pediatrics, and this is probably because it's these factors that reduce the number of counts in the first place. Given our initial goal was primarily to reduce dose while maintaining study quality, we ended up combining the satisfactory and the excellent scores together into a sort of combined diagnostic category, since we felt that as long as we had a diagnostically acceptable result, it doesn't really matter how high quality the study was. This ended up providing some interesting data points, as we discovered that the reduction in activity significantly reduced the number of excellent studies into satisfactory studies. However, the number of suboptimal studies only slightly increased by a much smaller degree. So overall, we only had a very small reduction in the total number of diagnostic quality cases. The results were pretty striking and changed a lot of the assumptions that we'd developed around our MAG3 renograms. So we are planning to implement several changes influenced by this study into our current protocols to optimise our dose and diagnosis ratios, and then to review these changes as an ongoing process. So overall, the adult patients with severe renal impairment were most likely to have suboptimal quality renograms. For all other adult patients with renal functions ranging from normal to just moderately impaired, reducing the amount of radiotracer from 100% even to 25%, and thus reducing the dose, had only a minimal impact on the diagnostic quality of the study. And that's from both a quantitative and a qualitative perspective. Therefore, our recommendation was to divide all adult patients into two categories, basically all of those with pretty poor renal function, which we set as creatinine of above 150, and then everyone else of okay renal function of creatinine less than 150. So with the patients with okay renal function, we plan to reduce their standard activity dose to 100 megabecquerel down from what we usually did as 200. And those with poor renal function, we'll maintain 200 megabecquerel. And one thing we added was that we'd preferentially scan those on our low energy general purpose collimators, just in an effort to try and increase the counts as much as possible in this group who naturally have a lower image quality. So the suboptimal pediatric studies, which was a bit different. So the pediatric studies that were poor were all cases that were where we had less than 30 megabecquerels administered, which means that younger and lower weight kids are at inherent risk of a non-diagnostic study. So we will therefore institute a minimum dose of 40 megabecquerel for all pediatric patients. We decided not to recommend using the LEGP collimators in this case because clinically we preferred the high resolution collimators since kids' kidneys are smaller and so we needed the high resolution. I'll note that we couldn't really assess the impact of severe renal failure in paediatric patients because we didn't have any subjects like that in our cohort. We may or may not be giving enough activity to paediatric patients with renal impairment, but the situation is slightly different to adults because we scale their dose based on weight, so the same rules probably don't apply quite as exactly. And so this is just a slide showing the summary of what our planned strategies are to implement to optimize our dose for our MAG3 renograms from now on. So in summary, the diagnostic quality of our MAG3 renograms was overwhelmingly determined by having a high number of counts per second. And in our practice, this was most easily influenced by the amount of radiotracer given, the renal function of the patient, and the type of collimator that we used. However, changing the amount of radiotracer activity even down to 25% had a very small effect on the overall quality of the study. In adults, severe renal failure is the main cause for low counts and therefore a non-diagnostic study. And in pediatrics, it was beginning with the low administered megabecquerel, which, as I said, is most commonly in the kids with low weight. One final thing that I want to stress is that these changes are simply local attempts at optimization rather than generalized recommendations. It's possible that between different sites, variability in scanning technique, in radiotracer usage, and say specifications of the equipment are different enough that our results may not be valid for other sites. But we found that, we hope at least, that these optimization strategies that we've developed will produce a real measured benefit in dose optimization and study quality for our institution. Thanks.
In the interest of time, I think we'll have to move forward, but if we have time at the end, we'll come back. Thank you.
Thanks. Just moving on to the final speaker now of the session. So this is Mr. Assam Ahibari. Thank you. Talking about an Australian local diagnostic reference levels for paediatric FDG PET-CT studies. And that's just out of Sydney University.
Yeah,
that's great.
That's fine. Thank you. Good afternoon, everybody. Welcome to my presentation. My name is Isam, and my talk today about an Australian local diagnostic reference level for pediatric FDG study. Radiation doses in PET-CT is a combination of dose from injected radiotracer and dose from CT acquisition. However, PET-CT may have a higher radiation burden to pediatric in comparison to the adult. This is because the rapidly dividing cells of children tend to be more radiosensitive, as well as they have a longer lifetime to develop potential radiation injury. The International Commission of Radiological Protection introduced the concept of diagnostic reference level in ICRB 60, published in 1990, and its implementation was recommended in ICRB 73, published in 1996. Establishing diagnostic reference levels enable to understand the variation between high and low radiation doses delivered from equipment. This could be possibly made through by comparing the median radiation dose facility against the national standard. If the median radiation facility exceeded the recommended national standard without convincing medical justification, this will trigger the need for equipment performance, protocol review, or dose optimization. Based on the ICRB 135, the 3 radiation doses often used to quantify PET-CT, which is administered activity for PET, volume CT dose index, and dose length product for CT component. And the current recommendation asserted that the reported national DRL should be reported based on 75th percentile for both radiation dose quantity, and for local DRL, it should be reported based on 50th percentile. Sorry. Establishing diagnostic reference level for pediatric patients is more complex than adult. This is due to that the pediatric have a broad range of size. The current ICRB recommended 135 recommended to use age category if the age only available measured during the DRL survey, as well as for the purpose of comparison with other published previous data. You need to collect at least 30 patients under each category, and for some circumstances, you can collect up to 20 patients based on some authors. With regard to weight category, the weight, some study shows that the weight correlate better with those than age. And the European Commission developed 5 weight category for doing the DRL. And the current ICRB recommended that if the weight is available during the DRL survey, then the weight category should be used to report a DRL for pediatric patients. In 2008, an Australian and New Zealand Society of Nuclear Medicine reported a DRL for 2 pediatric PET procedures. And the current published Urbanza National DRL report didn't include any report related DRL for PET-CT patients, as well as, based on the literature, no DRL for CT component, and national DRL runs to report the DRL for PET-CT procedure for pediatric. So the aim of my work is to propose an ideal local DRL method to report local pediatric PET-CT component based on age and weight category, as well as to report effective dose for pediatric PET-CT. With regard to methods, an ethical approval was obtained from 1 participant center. 2 questionnaires were mainly designed to collect the data, one related to patient information, and other questionnaire related to the equipment and scan protocol. We collected the data over 12 months, and the local DRL was reported for the administered activity, CTDI volume, and DLB. With regard to effective dose, the effective dose for administered activity was reported based on tissue weighting factor published in ICRB 128, as well as for the CT tissue weighting, effective dose for CT was reporting based on using the ICRB tissue weighting factor published in ICRB 103, plus using a software to enable the data calculation, the effective dose for CT part. With regard to result, this table shows the characteristics of 3 pediatric patients group. With regard to first group, actually, unfortunately, I got only 3 patients, so I don't think so it's good practice to report a DRL for 3 patients. We can see the number of patients per each group, and the average and standard deviation for age and weight per each group was reported. The participant center only have 1 PET-CT machine from Siemens, and their PET system occupied with time of flight and LYSO scintillation detector. With regard to CT, their system capable to provide 128 CT rows and automatic exposure control, and their CT machine was manufactured calibrated with 32 centimeter body Vanton. This table shows the characteristic of CT acquisition protocol for 3 pediatric groups. And we can see that the tube current was increased gradually from group age 5, 10, and 15. This is due to the broad range of pediatric size. Also, the scan length was varied among 3 pediatric groups. This table shows the proposed reported local DRL for administered activity and CTDI volume and DLB per each group. And you can see that the dose was varied from age 5, 10 to 15. However, with regards to activity per weight, we can see that the dose activity per weight in group age 5 was higher than the other two groups. This is because that the administered activity is weight independent, and the minimum amount of dose is 60 megabecquerel to obtain sufficient image quality. This figure shows the comparison of our local DRL method against the other published guideline for FDG only. We can see that the reported DRL for local DRL in our study was lower than in age 5, 10, and 15, was lower than European Association of Nuclear Medicine dose card and North American consensus guideline. This is because the participant center, obviously because different administered method was identified in this research, and the participant center used Guild multiplier chart, and they scale their weight based on adult reference levels, and the maximum dose given for the patient is 200 megabecquerel. This table shows the reported effective dose for each radiation doses, as well as the total effective dose delivered from 3 groups for pediatric patients. As we can see, the major contribution of radiation doses is from administered activity. With regard to this figure, this figure shows the comparison of our reported effective dose against other 3 published data. And as we can see that the reported effective dose for age 5 and 10 and 15 was lower than other identified published data. With regard to reporting a DRL based on weight category, unfortunately, up to the author knowledge, this is the first time we report an effective dose based on weight category. So I'm unable to compare my data with other published data in the field. However, I think it's a good practice to report it for future data comparison and promote the field to report a DRL based on weight category. In conclusion, the first reported Australian local DRL for FDG BIT-CT study, our reported local DRL method data was lower than European Association of Nuclear Medicine and North American consensus guideline. As we saw that the major contribution of total effective dose was from administered activity. Future work, further research should be performed in the field of reporting a DRL for pediatric patients to report a better, to encourage also the many centers to participate in national DRL survey. Part of my PhD project also to report a size-specific dose estimate for CT dose, as well as understand the causal factor between high and low radiation doses per each group, then propose a dose optimization method. I would like to acknowledge all the participant center collected the data, as well as Australian Nuclear Medicine Society for their fund to support my project, as well as Australian Institute of Nuclear Science and Engineering and ICT dose supplier. Thank you.
Thank you. Are there any questions?
Yep.
What do you think about the idea of, instead of using weight, but thinking about the size of do both administered activity and also for your category. So if you look at, say, waist circumference or something that relates to how big they are, which obviously is attenuation and how many counts you get from the activity.
Actually, I think the reporting size and weight is correlate better than age for reporting the dose. But up to this knowledge, up to this stage, I need first of all to understand the variation between doses. Then I will investigate if the size or weight it's better to be used and recommended to report it in DRL.
Can I ask if you collected height data as well?
What?
Did you collect patient height data
Yep.
as well as weight?
Yeah,
Because that could give you a
that's
few
right.
different parameters.
Yeah, that's right. That's I want to investigate the body mass index as well in comparison with size. Then I'll provide a recommendation.
I think there was another question.
Yep. A good question. Actually, as I mentioned to that, first of all, I need to understand the relationship between the patients and those, also the equipment and those. Part of my study, I would like to investigate the image quality. If we can find a way to reduce the dose without compromising the imaging quality, it will be fine. But up to this level, this is one part of my study. I can't address a good answer to this point at this stage.
Thank you. Any more questions? I'd like to thank all the speakers for this
Thank you.
session. We finished perfectly on time.
Thank you.